on. Here we go. So when we jump into your analysis, if you want to turn off your sound, that's perfectly fine. But if you want to be able to respond to the questions, because I'm going to be asking you, we're going to go over it. However, I want you guys to tell me what your answer is, and then we'll discuss it, okay? So we'll go over all of the urinalyses for each one of our cases, all 3 of the cases together. We'll discuss them. So everybody has the right answer. I know you've already submitted that. But with that said, I'm about to get to that, and we'll talk about one of the questions because I'm going to give you guys credit on one of the questions, and I'll explain why in a second. But to get started, what I first want to point out, because this is important for you guys to note, that we are right now on, let's see, we are on finishing up from week 11, getting into week 12. So week 12, you guys are going to end up finishing up some stuff with digestive. And the digestive system is what we're jumping into tonight. You're going to finish up stuff with that for this week. You're going to have some things that are going to be due. But the main thing I want you to see as we get into week 12, you guys will have a fetal pig dissection that you'll have to submit. I've already graded the dissection for the kidney, so you guys have all gotten grades. So you guys did a good overall job on that. But now we are going to have the fetal pigs, which you guys should already have your fetal pigs. So we're going to have dissections for that are going to be submitted on November the 15th. Okay. You will see it mentioned tonight on the lab. So you will notice that go ahead and we give you those instructions for you to know exactly what to do. However, it's due on the 15th. So it's not due in a week. You've got a little bit of time. So you've got about 2 weeks to do it. I just want to mention that because you're going to see, like I said, we're going to go over the instructions because I assume some of you will probably get into it this week or next week. Then you're going to have a digestive enzyme quiz, but we're not going to get into the enzymes. We're going to mention them tonight, but we are not going to get into the enzymes until next week. So I'll discuss them briefly. And the next week is going to be all about the enzymes of the digestive system and what do they do. So you'll have some virtual labs for next week because next week's lab is going to be mainly the enzymes. You would have had a major lab just about doing these activities with the enzymes, okay? For tonight, we're going over the anatomy of the digestive system. So if you look down here, you will see that there is a ton of virtual labs that are due by November 15th. So that's going to follow up next week. So you will have all of that to do because that will take up the majority of time for next week. However, with that said, like I said, tonight we're going over anatomy. Next week's going to be the enzymes. You guys are going to do all the virtual labs for the enzymes on next week. We'll still meet. I'll discuss it. We'll go over exactly what we need to do. So tonight we're getting into the anatomy. However, before we start into that, of course, I want to go over the case studies that you guys had to do for last week and turn in for the urinalysis. So first, we're going to jump over to the urinalysis case studies. We're going to go through them together. Like I said, if you want to turn your sound on, that is perfectly fine, just so you guys can give me a response to the answers. If you want to type it in, that's fine too. It just takes me a little longer for me to get over to see your response that's typed in because it comes up and I have to click on it and then see it, and then it just takes a little bit. So if you want to turn your sound on, I think that we'll be okay. I don't think we'll have much feedback. If I do hear somebody with a lot of feedback, I will just go ahead and mute you. Okay, so just keep that in mind. It's perfectly fine. All right, so I need to cut over so we can get to our urinalysis case studies. So that's what I'm going to do right now.
I have a quick question, if that's okay, as far as the pig dissection.
Yeah, absolutely.
So I don't have I have like a coffee table in my house. Would it be possible to maybe rent or just say that I'm going to be in one of the actual labs for a certain time, or just so that I can use the table space? Like, I don't want to be around other people.
I understand. That's not a bad question. You can email Dr. Eastman since she's on campus. I don't know about daily, but I think she's on campus pretty consistently. So If you want to email her and ask her that question, I think that's a reasonable question to ask if you don't have space to do the dissection.
Also, my roommate is like, it stinks in here. When I did the kidney,
Well,
I was so surprised that it actually smelled like urine. I was like, oh, I have the right organ.
Right. Well, and keep in mind, I don't know that they so much, it may be somewhat of the formaldehyde, but it may, I mean, who knows? That's so funny that you said that it smelled like urine on the
It
kidney.
totally did. I was like, okay, you're right. This is a kidney.
I've never personally, I don't feel like I experienced that with a kidney, but maybe you did. But you know, sometimes we get some of the organs and you notice that like they're fresher, you know what I mean? Like they've not been in the formaldehyde that long. So you may have gotten one that wasn't in the formaldehyde all that long before they shipped it off. So that wouldn't surprise me because we've been able to notice the difference. So that's interesting that you say that. Let's put it that way. All right. Now.
Oh yeah, I was like, okay, cat and dog, y'all are going outside for a little bit because I don't need you smelling some cheap kidney in here. Anyway, okay, so I'll email her. Thank you.
Yeah, email her and ask her. That's a reasonable question. Here we go. I jumped on the wrong thing. That's a reasonable question. I think that's, you know, why not email her and ask and just see what she has to say. Now, I will say this, though, and I think you guys have probably come across this. If you do want to get on campus, you know, you have to fill out that thing that says, I've had no symptoms of COVID and all this stuff. And then you have to pull in and they've got to allow you to be on campus. Now, she may be okay with that. There may be some rules that have changed to be a student, you know, coming on campus. But however, you guys are going to the testing center. So for the ones that are being testing, you know, have been testing on the testing center. So I would assume that would be okay. I wouldn't see a problem with it. But because she's, you know, she's full time, she'll be able to answer that question much more easily than I am. I wouldn't see a problem with it. But definitely send her an email and see what she says. I just don't want to give you any directive that it's a yes or a no. Does that make sense?
Yeah, absolutely. Nope, I'll email her. Thank you.
Oh, you're so welcome. All right. So let me jump over. Here we go. As you guys know, it's always like a challenge. There's so much information that we put out there for you guys. It takes me even a second just to like get to all of it, even though I know in general where I'm at. It's so sad. But anyway, so I'm jumping. There's the dissection, so I just skipped it. There's reference. I'm looking for the case studies, and I just had it up too, which is irritating to me. There's the video. I feel like we've put, there it is. I feel like we've, like I said, we've put so much on here. I see you. Can you guys see when I do the chat, by the way? Oh no.
I don't see anything in it right now, but
okay, that's fine. I just want to make sure when I'm getting some. Okay, good. I want to make sure. Okay, we will deal with that. I got the message that came through for the person that sent it. I just want to make sure that I'm not opening up something that's, you know, private and you guys can see it. All right. So the first one we're going to deal with is Holly. She's the first one in the row. So let's jump into this. I had some questions about Holly. So let's first talk about her. When I get to that question, I'll mention what has come up. And I feel like it's a reasonable question. So I am going to give you guys credit for it because it was funny. I noticed it and I thought back on it like, oh, I need to say something about it. But I will give you guys credit. So I'll mention it in a second. All right, now let's talk about Holly. Holly is 17-year-old cheerleader who took a bad fall, okay? She struck her head, recovered without ill effects. However, she's complaining of extreme thirst and going to the bathroom all the time. So she's estimating that she's urinating 6 liters a day, okay? So we're gonna look at her urinalysis and we're gonna see what's going on, all right? So if we come down here, we're looking at her urinalysis, and if you look here, here's the specific gravity. To me, it looks like a 1. I don't think anybody would dispute that. Here's the pH. pH looks like a 5. Here we're going, leukocytes looks pretty much negative. Nitrites negative. Protein, very light, looks negative. Glucose looks normal. Let's come down. All right. Ketones, really don't see anything, so that's a negative. Your bilirubin, negative. Let's see, bilirubin looks very light. Okay, so probably normal. And then here's blood. It looks negative. Okay, hemoglobin. Okay, everything looks good to me. I know these aren't a perfect way to test somebody, so keep in mind. But when I looked at the specific gravity, something looked off from what we discussed. Okay, guys, tell me what do you think? What looks off from the specific gravity? What seems odd about that specific gravity? That should be the first thing that you guys come across that you say, she's going to the bathroom 6 liters a day. That doesn't sound right. Okay, and her specific gravity is right at a 1. Okay. So now that we've mentioned that, let's go to the questions. We've noticed that, right? So what is the specific gravity of urine? Okay, hers, it's already mentioned here, it's extremely low. It's less than 1.001. So what is the specific gravity of urine? What did you guys put? Like, what is the specific gravity of urine?
Isn't it the concentration, basically like the ratio of the density between what's in the urine to how much water is in it?
Correct. That's exactly what it is. So you're looking at the solid concentration that's found in the solution, which is water. So we're looking at it and we're going, okay, well, hers is a 1, so it's less than, it has no solid concentration. That's concerning, okay? Now, if you had a 1.001, we could say, yes, you have a little bit of solids in there, okay? Hers is a 1. It's very, very, very low. But when you look up, hers is less than, right, what we would consider normal. We already know that. But what if we looked at the normal range? What would we, this is the question I'm talking about that came up. What is the normal range for a healthy adult?
Is it 1.005 to 1.030?
Where did you get the 1.005? I'm just asking. Where did you get that from?
I think I got it from the textbook.
Okay.
Because I had to look for it, but I'm sure it's incorrect.
No, you're fine. You're completely fine. And let me just explain something, because this came up, and even on our handout, it says, the one that Dr. Mobley put together that I published on here, it says 1.001 to anything higher is basically normal. Well, 1.030 is what's normal to that range. However, because of the way that this was done, and if you look in different textbooks, and we ended up pulling this, the way that this was actually pulled from our lab manual and the publisher. So if you look at different sites, some things will say 1.001 and range to about 1.005. Okay, does that make sense? So the publisher, when we put in the information, it immediately put it in, and we made it an automated quiz. So with that said, some people were putting in what was on the handout, which is not wrong. Of course, that's not wrong. Okay. I got some questions about it because it did mark off some people on question 2. Okay. Not everybody did it. However, some people put in 1.001 was, a normal low level. So I didn't want people to be marked off on it, because some things you'll look into and it'll say, well, as long as there's some solid concentration, that's normal, up to 1.030. Okay. I just don't want you guys to feel like you've got that answer wrong. So I'm having to go through them this week, and I'm going to evaluate for the people that did get it wrong. What was their answer, and did they put it within that range? So most things say 1.003 to 1.030. Okay. All right. So I just wanted to clarify that. Okay. So people weren't, if they were concerned that they got that wrong, that they may not have actually gotten it wrong, I just have to go through that question and, make sure and I look at all the answers, and I will give you credit for it. Okay. Is there an abnormal constituent in urine? If so, what is it? What did you guys get?
No.
No, there's not. Okay. What is the normal amount of urine that is produced per day?
1 to 2 liters.
Yeah, 1 to 2 liters. Based on this information, what disorder does Holly display? And we talked about it before in another case.
Diabetes insipidus.
Yes, diabetes insipidus. Which hormone is the problem?
ADH.
Yep, ADH, the antidiuretic hormone. So is the problem going to be hyposecretion or hypersecretion?
Hypo.
It is hypo, so it's not produced enough. So I want you guys to remember antidiuretic hormone. It's anti to diuretic, meaning a diuretic makes you go to the bathroom. I want you to think of it that way, okay? So it holds on to water, okay? So if she's going to the bathroom all the time, well, it has to be hypo. It tells you something's not right. Hypo meaning too low, hyper would be if it's too high. So this situation is hyposecretion. Number 8, which gland stores this hormone? Be specific.
Anterior pituitary.
Not anterior, but the, you were so close. Just change the first word that you said.
Is it posterior?
It's
then?
posterior. Yep, it's the posterior pituitary. Okay. What is the clinical term for excessive thirst? Do you guys remember that?
Polydipsia.
Yep, that's it. What is the clinical term for excessive urination?
Polyuria.
Yep, that's it. If you tested Holly's blood, would you expect her sodium levels to be high, low, or normal?
High.
Mm-hmm.
High,
So why would they be high?
Because there's a lot of sodium.
Well, there's a lot of sodium, but think of it this way. So what is she doing all the time? What do we say? She had 6 liters of what?
She's urinating a lot.
Yeah, she's urinating a lot. So if you're losing all of this fluid and your antidiuretic hormone's not working like it should, and it's not telling the body and the kidneys to reabsorb, then what's going to happen is all this water is going to be lost. But when you lose all this water, the concern is you still have the same number of sodium solutes. You're going to have the same number. But if you take away the water and you test somebody's sodium, the sodium's going to look like it's high, despite the fact that it's no higher than if you kept that water as opposed to losing it in your urine. So if the sodium solute concentration is the same, but you're losing all this water and you test their blood, you're looking at the ratio of the sodium solutes to the concentration of water. Does that make sense? Mm-hmm. So sodium's going to look like it's really high in your blood, okay? So would Holly's blood have high or low osmolarity? So we talked about osmolarity in AMP1. What do you guys know about osmolarity? So would it have high or low osmolarity? We're talking about her blood.
Isn't the water normally attracted to the sodium?
Right.
So
but
then
because she's losing the water, she can't help it because of the antidiuretic hormone. So because of that, there's a lot of sodium solutes. So what did we learn in AMP1 about having a high concentration of solutes in a solution? Was that going to be high or low osmolarity? Is that a hypertonic or a hypotonic solution? That's what we're asking you.
Hypertonic?
Yeah, it's hypertonic. So it's going to have high osmolarity. Does that make sense?
Yes.
Because you've got a higher solute concentration compared to those water molecules. So now you're looking at that and you're going, oh, this is a hypertonic solution. This has high osmolarity. So a lot of fluids are going to be attracted to it, right? But the problem is she can't help it when you don't have the antidiuretic hormone, she's going to lose it. But now the blood's going to become hypertonic or high osmolarity, okay? Now we could go on with that for quite a bit, but hold on, I'm going to move your little picture. Okay. We could go on with that, discussion on her losing all of this water and her blood becoming a hypertonic solution. Yes, all of her water, she's going to kind of shrivel up. But when you think about it, somebody that's lost of water, they're losing a lot of water like that. Their skin, all of that's going to wrinkle up. She's going to look like she's dehydrated because what's left there is going towards the blood. And then what's going towards the blood is eventually going to be filtered via the kidneys, and then it can't hold on to the water, and she's losing more and more and more. So there's a lot of things that go into play in her situation. Okay. If she was an actual patient, we would see some other things that are going on. Okay. Just because of the blood becoming hypertonic or high osmolarity. All right, let's talk about Molly. Let's move on to her. So Molly is a 4-year-old girl brought in by her mother. She seems like she's feverish. Okay, her mother explains that Molly hasn't been feeling well. She's been vomiting the last few days. You notice that Molly's breath has an odor like an acetone odor. Okay, so then you do a urinalysis and you look at her urinalysis and let's see what you find. All right, so specific gravity, to me, that looks like either here or here, 1.005 to 1.010. Looks good, okay, right? Then you look at the pH, okay? pH looks about 5, leukocytes, okay? Doesn't really look like there's any nitrites, nothing. Protein, negative. Oh my goodness, look at the glucose. Okay, so glucose looks really high here, okay? And then the ketones, you've got, you know, either moderate to a large amount of ketones that are listed here, okay? Urobilinogen, that looks normal, that looks like none. Bilirubin looks like none. Blood, none, okay. Hemoglobin, yeah, okay. So, all right, now, I've seen 2 things that don't look right, okay? So, are there abnormal constituents in her urine?
Yes.
What are the 2 things that we just noted?
Glucose and ketones.
Yeah, glucose and ketones.
Glucose and ketones.
Yeah, so what's causing the acetone odor in her breath?
The ketones?
The ketones.
Yeah, the ketones, okay? Based on this information, what disorder do you think she has? And we've already talked about this too.
Diabetes mellitus.
Yes, she's definitely has diabetes mellitus. What type do you think she has? Because she's a child, right?
Oh, type 1.
She's got type 1, okay. So which hormone is the problem?
The insulin?
Insulin.
Mm-hmm. Is this a hyposecretion or a hypersecretion problem?
Hyper.
Okay, so you're thinking of, you're thinking of type 2. So think of type 1. So is it hyper or hypo?
Hypo.
Okay. So guys, please remember when you're talking about type 1 and type 2, so for people that are type 1, which is usually diagnosed in adolescence, they're going to have an autoimmune problem. So when you have an autoimmune problem, it attacks the cells, the beta cells of the pancreas, and then they no longer can produce enough insulin. So that's going to be type 1. Type 2 is going to be where you're going to just overproduce insulin constantly. You're constantly producing insulin. And then one of 2 things happen. The pancreas can, 1, wear out. There's that thought. And then the other thought is the receptors get worn down where no longer you've overfed these receptors. You're saying we take no more, right? So then you've got both things. So resistance to the insulin because there's overproduction. And then eventually the insulin, it's like your pancreas just doesn't secrete the insulin like it should. So either resistant to what's being secreted or to a point where the pancreas is not going to secrete like it used to, okay? But type 1 is going to be a hyposecretion always, okay? Type 2 is going to be a hypersecretion and eventually turn into a situation of possibly a hyposecretion where it just cannot produce or it's going to resist, okay? So hyposecretion for type 1, that's where we're at because she's going to be a type 1. The gland produces this hormone. What is it?
Is it your pancreas?
It's your pancreas. You got it. I would hope that I had 10 people say that at one time, but I didn't. That's okay.
It's just me.
I would hope you'd be like, it's the pancreas. We know this. It's ingrained into our heads. Okay. So the next one says, generally Molly's version of this disorder is autoimmune. Okay, here it is in origin. Specifically, the cells are being attacked. I guess I already mentioned this. What are the cells that are being attacked?
Beta cells.
The beta cells. What would a blood test show?
Glucose?
Okay, so why? Why would the blood glucose be high?
Because she's hyperglycemic. There's too much sugar in her blood.
But why?
The insulin is not being effective.
There's no insulin, right? There's not enough insulin because
Right.
insulin takes the sugar from the blood and puts it in the cells. So if you don't have the hormone to take the sugar and put it in the cells, then the sugar, where's it going to go? It's just going to sit there in the blood. So you're going to eat and your body thinks you're starving because the sugar's not going into the cells. It's just sitting in the blood. And the next thing you know, you're peeing it out because there's so much sugar in the blood. Then those little tiny glomeruli are going to be flushed with this fluid, this blood that's going to have high amount of sugar, and it just can't help it because we talked about the glomeruli being like a filtration, just like a hose. So some of that's going to spill out into the urine. Okay. So she's in the situation of her blood test is going to show high glucose because she doesn't produce enough insulin to take it out of the blood and put it into the cells. All right. And that was a long-winded question or answer to even say, but anyways. All right, 9, along with the excessive thirst and urination, patients in later stages of this disorder produce an excessive hunger. Do you guys remember the term for excessive hunger?
Polyphagia.
What was the clinical term for the presence of glucose in the urine?
Glucosuria.
What about ketones in the urine?
Ketonuria.
Yep. So why is she going to have ketones in her urine? Okay, we talked about the glucose in the urine, but why high ketones? I know I'm asking you, even though it's not a question, but you guys need to know this by now. So why the high ketones?
Because there's no other way for them to leave the body.
So, but why, but here's the question. Why is she producing ketones?
Because there is no insulin.
Because her body's breaking down the fat.
Yeah, so the body's breaking down the fat, but why is the body breaking down the fat?
Because there's no energy storage.
Well, there's no energy. The body says there's no sugar, so the backup method is always fat, okay? So the body says, well, I have no sugar to put into the cells for us to run on, right? For metabolic reasons, you're going to go, I need to go to the backup storage, because if you starve yourself, the next thing that's coming next is fat. So now you're going to break down fat, okay? So now the breakdown of fat you're going to produce as the byproduct ketones. And now ketones are going to be in the blood, and you're going to find some in the urine because you're constantly breaking down the fat. So now we know she must be a diabetic. If we see sugar in the urine and we see ketones, we know, okay, she's definitely diabetic. It doesn't mean if she's type 1 or type 2. It just means she's diabetic, okay? All right, so fat breakdown is second to sugar. If we don't have sugar in the blood to put into the cells, the body will break down the fat to get the ketones, because we can live off ketones also, okay? All right. Dolly, let's talk about Miss Dolly. She is a 55-year-old woman. She's recovered from a severe bout of strep throat after 2 weeks. She has noticed severe swelling in her hands and her feet. You note that her urine looks very dark. Look at the results of your analysis. So let's do that. Okay, so her specific gravity looks to me about 1.010. That looks good. Her pH looks like it's probably a 6. Let's see. Leukocytes look negative. Nitrites, nah. All right, protein. Here we go. So protein looks like it's at 100. Glucose looks normal. Ketones, no. Urobilinogen, no. Bilirubin, no. Okay. And then let's see. Now we're looking at blood. So we're going to talk about this. So it kind of looks like there's not really any, but we'll talk about it. Let's see. Go and trace. Okay. I honestly haven't really paid attention to these dipsticks, and I don't know how good they are, but I do know what in general we're supposed to be answering. Okay, is there anything abnormal in Dolly's blood?
Protein.
Yeah, so we definitely saw the protein on there, right? So anything else? That's not a trick question. So just protein, right? All right. 2, in cases like Dolly's, the urine may have a dark brownish color. What would cause this color?
Bilirubin.
Okay, so you're saying bilirubin, but think more general. I guess not general, but what
Could be the
else?
albumin.
There is. We're gonna get there. We're gonna talk about albumin. Yes, but what else? What else could color your urine?
Is it the protein
Blood.
itself?
Blood. He just added blood.
Mm.
So blood could color the urine. That's our kind of our easy, like, oh, well, blood could get through and color your urine. Okay. So we're going to talk about albumin in a second, though. All right. Number 3, Dolly's case, her antibodies, okay, have become trapped in the kidneys. This has caused an inflammatory response, damaging the area. Which specific part of the nephron is affected?
The glomerulus.
Yeah, the glomerulus or glomeruli are affected, right? Number 4, is this part of the nephron in the cortex, medulla, or pelvis portion of the kidney? We talked about this specifically. So where did we talk about those nephrons being located?
The cortex.
Yeah, in the cortex. Okay. All right. So number 5, what clinical disorder does Dolly probably have? I know this doesn't, you guys are probably not going to say this right, and that's fine. I don't expect, I know you've looked it up, but I don't expect you guys to be super knowledgeable in this term. Go ahead. What do you guys get?
Is it acute?
Glomerular nephritis.
Yeah.
But let me ask you this, because this is something I debated. Were you guys able to find that term fairly easily?
It was in the textbook.
Yeah.
Okay, good. I just want to make sure that everybody looked at their textbook. You should have found, like I said, it says it's in your textbook. You should have been able to found it, you know, pretty quickly, but I don't know. So I didn't get any questions about it, so that's good. Number 6, which particular plasma protein would be in high levels in the urine? So let me go back and just preface something before you answer that, before you say anything. Keep in mind, if you have protein in the urine, you're going to be referencing a certain type of protein, okay? Those dipsticks are very general, okay? And I don't care who you go to. If you get a dipstick's very basic. So the dipstick, when it says protein, the protein is just in generally talking about a specific type, or I should say specific types of protein, but the most common protein in the blood is the one that we're talking about. So which particular plasma protein would be high? So what plasma protein would be high in her urine? You already know it's protein, but this is the type of protein that we're talking about.
The albumin.
Albumin is exactly it. Okay. What is the clinical term for the presence of protein in the urine? This is for albumin. What is it called if it's in the urine?
Is it albuminuria?
Albuminuria? Yeah. That's it. So when you hear a protein in the urine, you're talking about albumin. Just FYI for all of you, okay? Just so you're aware, when we're talking about protein, we're not talking about actual just, you know, I know that sounds, it's just such a general way of saying albumin is in the urine, okay? Because albumin is the most common type of protein found in the blood, and the reason that is it helps with osmolarity, so blood pressure and for water to be pulled into the blood vessels, but it also is a transport protein for hormones, different types of nutrients that need to be, like certain vitamins that are fat soluble or need to be bound to that protein where it can't just float in blood. So keep that in mind. So that's the type of protein we're talking about. We found protein in your urine, we're talking about albumin. Why does Dolly have protein in her urine?
She's got proteinuria.
Yeah, but why? From what we talked about above, why does she have protein in her urine?
The kidneys aren't filtering properly.
But why aren't they filtering properly? I mean, that's right, but why aren't they? I want you guys to think about it. Why is that? We talked about inflammation. It said, if you look above, it says antibodies were trapped in her kidneys. So if you're thinking about antibodies, they must be attacking the kidneys. So, and you've already told me glomerulonephritis was the condition. Yes, you looked it up, but what does that mean? What's wrong with the glomerulus?
They're being attacked or
Yeah,
dysfunctioning.
so what's it doing to it? If it's being attacked, it's probably damaged, right? If it's damaged, then it's not going to be filtering things properly. So a lot of things are just going to pass through, especially the albumin, these big proteins that shouldn't pass through. If you have damage to the kidneys, whether that be high blood pressure, whether that be, you know, antibodies, whether that be somebody hits you in the back, for example, really hard, then if it damages the glomeruli, the next thing you know, things are going to pass through that shouldn't pass through, okay? And one of the key things that they look for is protein, the albumin, because albumin is a protein that's commonly found, it's always found in the blood because it has all these functions it has to do. So when they say protein in your urine, they're talking about albumin. But why, okay, so here, this leads into the next question. Why are Dolly's hands and ankles showing edema?
Because the whole filtration system is off balance. So if the kidneys
Okay.
aren't filtering,
So
then
this is kind of taking the albumin question and seeing how well you understand albumin and its function. So the reason her hands and her ankles are showing edema is because without the albumin being in the blood, you lose that osmolarity that's found in the blood, because water would follow into the blood vessels and it would bring up the blood pressure and it would leave the interstitial spaces, for example. But the problem is, if you don't have albumin, which albumin really helps with blood osmolarity, it's not just a transporter, but that's one of its major functions. When you look it up, you'll go, oh, that's a major function for it, right? So if we don't have albumin, and albumin is, you know, it's populating throughout your blood, there's so much albumin because it has so much, you know, functionality for the blood. But one of the major functionalities is to create a hypertonic solution in the blood for water to be pulled in and to bring up blood pressure is one of the components. If you don't have the albumin, then there's no reason for water to come in the blood vessels, okay? It's going to stay in the interstitial fluid, and then eventually it's going to leak out and the hands are going to swell, your fingers are going to, you know, you're going to have edema because now you've lost that albumin. I hope that makes sense. Here's that whole what's hypertonic, the osmolarity question, okay? What's hypertonic, what's hypotonic, okay? But albumin played a major role in osmolarity for blood, okay? So that's why now you're gonna have edema found in the ankles and in the hands. You know, that sucks, right? So that's one of the things. In fact, I'm going to try to relate it to something. So if you guys know anybody with kidney failure, one of the signs and symptoms of kidney failure is going to be swelling in the hands and the feet, especially you're going to follow gravity. So the feet are going to be really one of the first things. So if you know somebody with kidney failure, you're going to see swelling, okay, in their feet. And that's because of the loss of albumin, because they've already had damage to the glomeruli. So albumin's being passed out. So you've lost that perfect osmolarity for the blood. So now you're swelling in your extremities at this point. So that's what's going on. And you can think about somebody, hopefully, if you know somebody with kidney failure, you can actually see it, okay? All right, patient Holly, what was the name of the disorder?
diabetes insipidus.
Okay. What was abnormal in the urine? What was abnormal about the urine? Let me say that.
The concentration of it, the density.
Gravity.
Yeah, the specific gravity was really crappy. Like it was really dilute. It was like straight distilled water. There was nothing in it. Okay. Signs and symptoms for diabetes insipidus.
Polyuria.
Polyuria. Okay. What about Molly? What was the name of Molly's disorder?
Type 1 diabetes mellitus.
Yep, type 1 diabetes mellitus. Okay. What was abnormal in the urine?
Glucose and ketones.
Glucose and ketones. What are signs and symptoms?
Excessive hunger, thirst.
Yeah, polyphagia, dyspepsia, all of that is going to be signs and symptoms, right? And then, of course, I mean, you can elaborate on that one, diabetes mellitus 1, of course. What about Dolly? Name of the disorder for Dolly?
Acute glomerular. Yeah, that's.
Yeah, that term. Glomerulonephritis. That's it. Good effort. Good effort. Okay.
Thank you.
What is what is abnormal in the urine?
The protein levels.
Yeah, so you definitely protein levels. So protein, when we talk about protein, like we said, we're talking about albumin. What are the signs and symptoms?
Color of the urine.
Okay, so one, it could be color of the urine because like it passed through, right? That's one of the things. What about swelling in the ankles, the feet? That's a possibility, right? And then another thing would be possibly running even a fever, you know? If she's having antibodies and they're attacking her, you know, we don't know what's going on because she sounds like she has a strep throat. So for her condition was more complex. So I'm just talking about her, but swelling, blood in the urine, that's one of the signs and symptoms. I don't want to say, you know, albumin being in the urine because that's something we test, but for the signs and symptoms of swelling and then seeing some blood in the urine would be something that you would see that she could assess herself, right? All right, so any questions on the urinalysis case studies before we move on? Because I'm already moving on. Watch me. Here we go. All right, so if you have any questions, just, you know, you can text me, you can email me, let me know that you're lost in some form or way. All right, I'm going over to the objectives for digestive system. That's actually where I'm headed right now. And by the way, I know I'm changing throughout. If you guys ever can't see the screen, please notify, please go, hey, we can't see what you're talking about. It's concerning to us. Let me know, because even I think one time it knocked it off, just me changing throughout eLearn. I don't really understand it, but please let me know, okay? All right, let's go to lab instructions for digestive anatomy. That's where we're going. So the objectives for tonight, all right, you should be able to describe the functions of the digestive system, relate these functions to the various structures of the system. So we're going to talk about that. We're not going to be done with it because I have some things I want to talk about next week before you guys do the virtual labs. But keep in mind, we're going to talk about it in a general basis. This is going to be elaborated in lecture, and then we're going to talk about it more from a chemical and well, of course, a mechanical aspect too when we talk about it tonight, but we're going to talk about the enzymes and kind of like the chemical breakdown of these enzymes. What are they doing? What are they breaking down next week? But for tonight, we may mention some of that, but we're going to get into it and we're going to basically continue this section next week. Describe the tissue layers of the alimentary canal, which is the digestive tract. The GI tract is what we're talking about. And then we're going to talk about identify the structures of the digestive system on the various models, photographs, figures, etc. Those are the ones that you're going to be looking up below, just like we do every week when you have to pull them up on the, you know, on your Connect, and you have to get on and look at all these things and go through the anatomy, the dissection tool, pull up all of these because all of those could be, you know, be questions for later for the exam. All right. Then locate, identify selected structures of the digestive system on the dissected fetal pig. All right, so you've got 2 weeks to get the dissected pig, to get the fetal pig dissected and identified. But one thing I want to mention with this, and we'll go over this a little bit later, it's not just the digestive system that you're going to be locating on the fetal pig. It's going to be things that we've already gone over, like the heart, the lungs, just different things, okay? The reason that is, let me just say this. Because it's hard, and it's not, I'm not saying that some schools don't do this, I'm just saying we don't do this. It's hard to open up your fetal pig and save it unless you're going to stick them somewhere, and that's not reasonable for at home, okay? So we're not going to ask you to do that, but we are going to ask you to locate some structures that are beyond the digestive tract, because while you have a fetal pig open, you need to take advantage of it, okay? That's the whole idea. All right, there are some definitions you need to know. deglutition, peristalsis, segmentation. We're going to talk about those. They're on your handout. So if you want to reference back to them, they'll always be on your handout. They're always there for you to look at. All right. Then, of course, you've got some stuff for like video wise for this chapter you can look at on Connect, and then the Anatomy Physiology Reveal, the anatomy cadaver tool. You've got several things to look at. Now, keep in mind, it will take you a long time. I feel like it should take you quite a bit of time to go through Anatomy Physiology Revealed on Connect, because there are so many structures you need to look at. Now, even though there's so many structures for you to look at, all of them are differentiated. All of them are very different from one another. They are not similar. So once you get one down, you'll get it down. It's not that hard, but there are a lot. Okay, so we're going to talk about these structures though, so hopefully it will help you before you get into it. I do not have time because there is a bunch. There's some things like you're going to look at, like oral cavity proper. I just noticed that there. The oral vestibule in between, basically, I don't have a good picture of that right now. But I want you guys to make sure the little things like that you look at. Of course, there's some easy things like hard palate, soft palate, oropharynx, laryngopharynx. We've talked about those before. We've looked at them. And some of the things are very obvious you're going to look at. Let me go down. Now, I do have a picture that's not on the handout, but it's on the additional, I put pictures on a document just to be able to discuss them with you and for you to be able to see what I'm looking at or talking about when we do reference something. And I can post it on there. That's perfectly fine. I can put it on eLearn. But one of the things I want you to look at and make sure you do not skip is the salivary glands, because there are 3. And although, you feel like, okay, I kind of know where the parotid or sublingual or submandibular gland is going to be, make sure you look at those. Okay, make sure you pull them up. Definitely get those down, because trust me, you can go into an exam and think you know which one you're talking about and still get confused. All right. Now, common things: esophagus, stomach. And then here's for example, like I said, there's a lot for you to be able to identify. So here we go. We're going into the stomach and then the duodenum as we start into the small intestines and continue on. But make sure you point out all of these and look at them, like the cardia of the stomach. We're going to talk about that. I've got an image of the different locations of the stomach, and all of these different things I can discuss with you, and I am going to discuss with you, but make sure, like I said, look up all of these. All right, one of the things I don't have a good image of, and I think that we're going to next week, I'm going to come back to, because of talking about the enzymes and the different roles that are played by what we're going to talk about is the accessory glands. The liver is one, it's a key thing you need to look at, but I'm going to continue into and talk about the liver next week, because the liver produces or has and creates bile, I should say. Bile gets stored in the gallbladder, and the bile plays a major role in digestion. So that's something we're going to talk about next week. Also, I will come back to the liver. You need to be able to get in your mind that the liver is part of digestion. It plays a major role with that. And you need to be able to see where the liver in your head, you should be able to go, I know where the liver is located. I know where the duct is coming out of the liver for the bile. For example, here's the gallbladder. You're going to have a cystic duct and a bile duct. And where is it located, and where is it in relation to the duodenum? So that's something I want you guys to be able to image in your head. You should be able to close your eyes and go, I know exactly where that is, and I know how it's connected to the GI tract, okay? So make sure you look up all of that and feel pretty comfortable, because when we talk about it next week, although I'll go back to the structure and I'll show you where bile is coming out, because I want to reference it again, I want you to be able to know in general and feel like you've got those structures in your head and where they're located if you close your eyes, okay? That's the whole idea. Now, with the bile gland, or when we talked about it, there are different ducts. Like I said, I mentioned some of them. That's why you need to be able to look at this and be able to separate visually which duct is which. Where is for example, the cystic duct, where's the bile duct, and then where's the pancreas, and then where are the ducts that come out from the pancreas, and they meet together, FYI, but you got to be able to see this, visually see this. So although the GI tract overall, you'll be able to go, hey, you know, I know where in general you talk about the small intestines, the large intestines, and those are easy things, but the liver and the pancreas and how they connect into the duodenum, I want you guys to be able to visually see those things. Another thing that's a little different, and I do have a picture of this, but I don't have an awesome picture, but when you do your fetal pig dissection, you will be able to see this, and it is very different. It is neat, but the peritoneum has something called the omentum, okay? You have a lesser and a greater. We're going to talk about those. But the greater omentum covers up all those digestive and like all the digestive organs, all the organs in the peritoneum, all of that, okay, is going to be covered by the greater omentum. And when you cut open your fetal pig, you should be able to see it laying over, okay? I think we've got a picture down here and I'm going to show it to you, but you have a greater and a lesser. So we're going to talk about those too. Make sure you pull those up. If you need to pull them up separately on Google or whatever to be able to understand what we're talking about, this has, let me just say this, these have a good function in immunity. And they are odd structures, so I want to make sure that you guys see those. And if you're confused when you look them up on Anatomy of Physiology Revealed, please make sure you pull up another image. I do have an image just in general to talk about them, like I said, but I need you guys to be able to make sure you know what you're looking at, because when you dissect your fetal pig, you will see it. I just don't want you to miss it. Let's put it that way. Okay. Now, accessory glands and organs. Let's talk about here's what's listed here. We're going to talk about it again on the handout, but accessory glands and organs are going to be things that are an accessory to the digestive system. For example, the pancreas, liver, and gallbladder. I want you to make sure you get those down. We're going to talk about it, I promise, in more detail, but do not miss any of these to look up. Even if you think you know, you probably may not know, okay? So then the other thing with the gastrointestinal tract, so make sure you go through and go with an order, like stomach, then duodenum. Duodenum's start of the small intestines, and the jejunum, and it turns into the ileum. We're going to talk about all this. And then lecture, you'll talk about it too. And then here's talking about the colon or the large intestines, okay? So a lot of, if I've not made my point, there are a lot of structures for you to pull up on Anatomy Physiology Revealed. That should take some time. And if you pull them up and you're still confused, you need to pull up another image, or we need to talk or something, but it shouldn't be complicated. It's just a lot of images to look at. That's all I'm trying to get down. Now, we do have some images right here on eLearn. For example, just to give you an idea, I have these, I'm gonna go over these. These are also in your book. But just so you can see, here's the stomach, here's the beginning of the small intestines, there's that duodenum. Here it comes down, turns into the jejunum, and then the ileum where it ends. And then we hit a ileocecal valve, and here's the colon going up, ascending, transverse, and descending, and then the sigmoid colon. We're going to talk about all this. This is just to be able to show you an image. We've posted some on here. And that way, when you go through and you look at these, you can compare these images too. I will come back probably to this image. I do like this image. I don't know that I posted one like this that divides it up. This is all the large intestines. So all of the colon, okay? So I'll come back to that and we'll talk about it. All right, 15, can you map out the digestive system? All right, that's a great question. So something that you need to have as a goal is, can you truly map out the digestive system from the moment you eat something and it travels down the digestive system and it continues through? Where all does it go? You should be able to get that down and know structure to structure, what does it hit? So that's something that you need to have as a goal when you study and learn about the digestive system. It is not an easy fly-through process. It's kind of like when we did the kidneys, we talked about the flow of the blood. but you need to talk about the flow of the food and what does it turn into and how does it get absorbed as it goes through the process. All right. Okay. This is dissection instructions. I will just mention this for a little bit, but however, we'll get into the handout in just a second and we'll come back to this. But it is right here. We do have a fetal pig dissection video, so you do know what's expected, what should you be looking for, right? And then we tell you exactly what to do, like last time. The only, of course, the concern with the dissections are if you do not follow the dissection basically step by step, you are going to be counted off. And I think some of you have probably experienced that. Well, yes, you understand where the location of this structure is. Yes, you stuck a pin through it, but if you didn't put your name and you didn't put the date and you didn't give an image for exactly how we told you to put the image and send it to us via the Dropbox, then you lose points, unfortunately, and it's so sad. But you guys need to follow this step by step. So we'll just come back to that, okay? And then you've got at the very end, let me go all the way down. At the very end, you have your post quiz, okay? I believe, I have to look back. I believe it's due the 15th. I'm pretty positive. If I'm wrong, please look at the due dates. That's why sometimes I start this with the due dates, because I think you guys need to look at them once in a while. I'm just kidding. You need to be looking at them constantly, just so you don't miss something that's due, okay? All right, now that we've gone through that, now that I've harassed you on specifically what I want you to do, let's go to the handout. Let's talk digestive anatomy. All right, here we go. Okay, so what are functions of the digestive system? Well, anybody could tell me, well, of course it's to break down food, but we're breaking down food to the smallest molecule, the smallest nutrients that we need. And then the things that don't get digested and don't get absorbed turn into feces, right? But one question I have for you guys as we're going through the handout, what are the smallest molecules of food? What are they called? What do we talk about in A&P1? Do you guys remember a general term for the smallest when we talked about organic chemistry and we talked about the breakdown of certain, like, for example, proteins, we talked about lipids, we talked about nucleic acids, we talked about fat, for example. What was the general term for the smallest molecule of these different organic molecules? Do you guys remember that?
Would different ions be one?
No, but we had a term for these. So we talked about, for example, let me just give you a general example. We talked about polysaccharides, for example, and polysaccharides got broken down to its smallest form. But instead of saying, well, polysaccharides turned into, you know, glucose, for example, what did we call the general term?
Was it monosaccharides?
Well, monosaccharides, hence monosaccharides is a term for example, monomers. Okay, do you guys remember the term monomers we talked about? Anybody? Did anybody talk about monomers in A&P1? Please, please.
Oh, we totally did, but.
Okay. Monomers were the most basic form of, just like you have specific names for each, but they were the most basic forms, like, for example, proteins get broken down into amino acids, right? We talked about nucleic acids, for example. We talked about, for example, the carbohydrates had to be broken down, like we talked about he just said monosaccharides. Lipids had to be broken down into, for example, maybe it was the, you know, the glycerol and the trifatty, you know, the fatty acids that were attached to it, for, you know, a triglyceride, for example. Then we had, so we talked about the different monomers, and you guys understand what I'm talking about now. So the monomers are the most basic form for these things to be that's the digestion process. So we used hydrolysis to break down. Remember we talked about hydrolysis? We used water to take these long chains, right, and break them down into their monomers, the most basic form. And the most basic form will get absorbed via our digestive tract, via our mainly our small intestines, and get absorbed into the body via the blood. And now here we go, we've got it in the blood and we can pass it on to the rest of the body, okay? So you can kind of think of, I hope that kind of backtrack to kind of make sure that you understand those organic molecules. This is what we're talking about. They're being broken down via hydrolysis into monomers and then absorbed into the digestive tract and then absorbed via into the blood, okay? But we think of the digestive tract kind of like a disassembly line, hence not an assembly line, but we take things and we break them down eventually, but we slowly have to go through a process to get it further and further broken down, okay? Until it's available into its monomer form to be absorbed via those cells, right? And then now be put into the blood, okay? So the alimentary canal or the gastrointestinal tract digests and absorbs, but what does it do via the different structures of the digestive tract? So technically, I want you guys to think of this, and this is on the handout, and it's a reminder for me to mention this, but the digestive tract is kind of like, I don't want you to think of it being inside the body. It's really outside of the body. I know this is going to sound crazy, okay? But we view the digestive tract as being outside of the body. Why do you think that is? Why do we consider it basically outside of the body? Why would the GI tract be considered outside of the body?
Because the food material only contacts cells lining the tract.
Okay, yeah. So I want you to think it as an open tube from the mouth to the anus, okay? And what's happening is it's a tube. So you have the opening of that tube, and then you've got these cells that are these epithelial cells that are lining the tube all the way through. And as we break down food through this process, going down this tube, eventually will get further broken down until it can absorb and get into the body. Does that make sense? Are you guys following me with that?
Mm-hmm.
Okay. All right. So now your view of the digestive tract is totally different, right? Because now you think it's inside the body, but it's really, you're like, okay, now I see how it could be considered outside of the body. Okay. So what's happening? You've got the mouth is ingesting food. And when we talk about the ingestion of food via the mouth, we have chemical breakdown via amylase, okay? Amylase breaks down sugar, right? Or breaks down to sugar, the carbohydrates. So we've got some amylase being secreted, and we have the mechanical breakdown of food via the teeth and the tongue, okay? So when you talk about the mouth is, of course, part of a primary structure of the digestive tract. However, the teeth and the secretion of amylase and via the salivary glands are going to be accessory, okay? So the mouth is just a start, but the teeth and the glands are going to be accessory to that, okay? And then from the mouth, food enters the pharynx, okay? And the pharynx is just going to conduct the pass of food from the mouth to the stomach. There's no digestion, no absorption. It's just literally the tube and process of passing it through. From the pharynx, we're going to end up in the esophagus. So it also is a passway, okay? Conducts a pass of food from mouth to the stomach. No digestion, no absorption, okay? So mouth, pharynx, esophagus are all going to consider primary structures of the GI tract. Okay, or the digestive system. The teeth, the salivary glands, all those glands that we're going to talk about, those are going to be accessory, okay? Now, from the esophagus, you're going to pass into a sphincter we're going to look at in a little bit, and food is going to enter the stomach. We'll come back to this. Food is considered, when it's broken down from the mouth, from the esophagus, entering down to the stomach, is considered something called chyme. It's on the handout. We'll talk about it in a second. Chyme at this point will enter into the stomach, and chemical breakdown and physical mechanical breakdown will happen. Now in the stomach, there is a enzyme. This is what we're going to talk about next week, okay? which is known as pepsin, but what it's going to do is it's going to further break down now the protein further down into hopefully amino acids, okay? The chyme is now fully converted, okay? But chyme is now going to be passed. Now it's fully broken down to that full chyme, okay? Now it's going to be passed from the stomach into the small intestines. And one thing I didn't mention to you guys, I want to go back for a second. When you are chewing your food, once it's finally chewed down and eventually at first when it gets broken down, you'll hear the term bolus before it's actually turned into further breakdown into chyme, okay? Now that it's in the stomach, it's further broken down and we'll term chyme because of the further breakdown, okay? The stomach has chemical breakdown, of course, and it's going to have physical breakdown, mechanical breakdown, because the stomach is very muscular, okay? So the stomach has muscles in 3 directions, which we'll look at in a second. So the stomach is going to churn, okay, turn the food, and chemical breakdown is going to happen. Now the food is going to go from the stomach into the small intestines through a sphincter we're going to look at, okay? So all of this is considered, like we talked about, mouth, pharynx, esophagus, stomach. Those are primary GI structures. Now we're in the small intestines, another primary GI structure, okay? Now, we've made it from the stomach into the small intestines. Here we have major digestive. We have a lot of enzymes that are going to be secreted out via the pancreas, okay? We're going to have bile secreted via the liver at this point, okay? And absorption activity is going to happen via the small intestine. So the small intestines goes the duodenum, jejunum, and then eventually to the ileum. Okay, so there's going to be a lot of absorption that's going to happen. Large intestines, the next primary GI structure, okay, that's going to be your colon that we were just looking at just a while ago. The major function is going to be propulsion, so to move the matter and turn it into fecal matter. What's going to happen in the large intestines, just to give you guys, and we're going to hit back over all this, but the large intestines is going to absorb water, electrolytes, and vitamins from what's left of the chyme and eventually turn it into fecal matter, okay? All right, any questions so far? Because we're going to continue through this and we're going to talk a little bit more about exactly what happens, okay? Once again, I've just mentioned in general with it. Okay, so if we were supposed to look at all this, we talked about it in general, what's happening where in the body, and we're looking at these structures. Of course, you have ingestion, the intake of food, okay, into the mouth. We have propulsion, so moving the food, swallowing, and then something called peristalsis that's going to happen to move the food through the GI tract. Peristalsis is going to happen via a wave-like kind of, it's literally the tube forming waves to push the food back and forth down. So if you think of, for example, I may have to unshare you to show you this for a second. Let me do that. So if you think of the sides of the digestive tract, basically going in a wave-like manner, it's pushing the food via these waves down through the digestive tract. So if, for example, even if you weren't upright and you turned yourself upside down, peristalsis is still going to continue to push food in the direction of the mouth to the anus, if that makes sense. Now, mechanical digestion is also happening via chewing, mixing of food with saliva by the tongue, and then of course churning, or the compressions of the smooth muscle of the stomach, okay? Flipping and crushing the food and flipping it over, right? And then we have chemical digestion, which is the breakdown of food that happens via the mouth. For example, it starts with amylase, and essentially it's getting broken down via the enzymes that are produced in the stomach, okay? So to break down protein in the stomach, and then eventually further break down with additional enzymes in the duodenum, okay? That's the start of the small intestines via the pancreas, and also the bile that's produced via the liver, or the gallbladder that's attached to the liver, okay? Absorption is going to be the uptake of nutrients from the GI tract and put into the blood or the lymph, and the small intestines is going to be, of course, the major component of absorption, okay? That's going to happen. And then, of course, defecation is elimination of the indigestible matter of food that gets clumped together after we've taken out the water via the large intestines, and then you'll release it out, okay? All right, ingestion, mechanical digestion, here's chewing, churning of the stomach, and then you've got a term over here called segmentation. I've got it on the other page too. Segmentation. So what's happening is, in addition to peristalsis that's happening, also what's going on via this GI tract is you'll have these segmentation happening because of the crunching back and forth. It's kind of like having a compactor on the sides in addition to peristalsis that's going to break up the food into small pieces, basically. So the smooth muscle is going to not only form waves, but it's going to form like a compactor on the sides and break down the food as it travels through via segmentation. And it's mainly happening through the small intestines, okay? So think about it that way, a little compactor that's kind of breaking and it's going back and forth. And we'll look at the small intestines and kind of go back through this in a little bit. Now, propulsion is going to happen via swallowing in the oropharynx. Peristalsis starts after you've swallowed food and you've actually taken the voluntary action of yourself with your tongue in your mouth, and then eventually it becomes involuntary and turns into the peristalsis from the smooth muscle, okay? So esophagus goes to the stomach goes to the small intestines and to the large intestines. And then absorption into the blood and, of course, the lymph vessels. And then once you get down from small intestines to the large intestines, water is going to be reabsorbed and fecal matter is going to be formed. Now, one thing to think about, two different things that could happen: diarrhea or constipation. We're just going to talk about it while I've got this image up here. Diarrhea happens when this food matter, okay, this chyme goes through into the large intestines and it moves very quickly. There's no time to reabsorb the water. So if it moves through very quickly, it's just going to flush out all the other fluid that should have been reabsorbed, for example. Now, constipation, for example, is going to be when things travel very slowly through the digestive tract and they end up in the colon, and it's not, the peristalsis is slowed down and it's sitting there for too long. Then you're going to absorb water, too much water, for example, and then it becomes hard and compacted. So the longer it sits, the more constipated you'll get, for example, okay? Because that's the function of the large intestines. But if you slow it down, then you're going to be constipated. If you speed it up, you're going to have diarrhea, for example, okay? All right, and then of course ends out via the anus. I know y'all didn't think we were going to talk about constipation and diarrhea tonight, but we are, okay. All right, now let's talk about from the esophagus to the anal canal, okay, those walls, right, that we're going through the digestive tract. Well, let's talk about the walls. They're also called tunics. We've talked about tunics before, okay? But when we talked about the digestive tract, we're going to go from the deepest to the most superficial layer. So the first one, the deepest layer, is the mucosa, okay? So it is made up of a simple columnar epithelium, and it has the little goblet cells that can produce mucus. What does it do? It functions for secreting mucus, digestive enzymes. Of course, there's absorption, and it secretes hormones. Of course, it could also plays a role, just like, you know, all other tissues of the body. It's got some type of protection from like some type of immune function too, or immune cells. Especially you're going to think the digestive system is, because it's going to be in contact with foreign matter that's entering your body that's a food substance, okay? So of course there's going to be protection via some immunity there too, some immune cells. Then we've got from mucosa, the next layer out is going to be the submucosa. It's made up of areolar connective tissue, which is what we talked about in AMP1. So it's got blood, it's connective tissue, so it's got blood and lymphatic vessels found in this tissue. We've also got nerve fibers found in this tissue. So nutrition and protection are the main function of it. All right. The next one out, so this is the deepest, this is the next out, and then the next one is going to be the muscularis externa, or the I should say just muscularis. Sometimes we use that term. That's why it's listed like this. It is primarily smooth muscle. It is responsible for the peristalsis and the segmentation. So peristalsis, the wave-like action that goes, pushes the food down, segmentation that happens that squeezes on the chyme that's coming through and breaks it up, okay? The next one out, which is going to be the most superficial, is going to be the serosa or the visceral peritoneum. Where have you heard serosa from before? What do you think serosa relates to?
The liver.
What does it relate to from AMP1?
Cirrhosis of the liver.
No, that's a different cirrhosis. That's different. What is serosa talking about? We also have this type of membrane found in other structures. It is talking about a serous membrane, okay? It has serous fluid found there too. So the outer layer, the most superficial layer of the GI tract, okay, from the esophagus going down through the stomach, all the way down is going to be, the superficial layer is going to be a serous membrane called serosa, but we're going to talk about that a little bit more in a second. It is made of areolar connective tissue covered with a mesothelium. So squamous cells are going to be there, squamous epithelium, all right? It's a serous membrane, so what happens, because it's found in the peritoneum, right? It's the visceral structure, right? So it reduces the friction of digestive organs that are around it that can slide on it. Remember, we talked about serous membranes, and that's what it does. So areas outside the abdominopelvic cavity, just to keep in mind, so you know this, everything above, outside the abdominopelvic cavity, above, okay, is going to be called adventitia instead of serosa. So it's a fibrous connective tissue. So when you think about, for example, going from the mouth, from the esophagus going down before it hits in the stomach, it's going to be fibrous, called adventitia, because it's mainly just connecting to everything. There's no movement or sliding or gliding across other organs, for example. So it anchors and protects to the surrounding organs. I hope that makes sense. All right, there is an image here. We're going to talk about this image real quick. Hold on. This image, let me move your faces over for a second. This image is broken up into the different layers. For example, here's the mucosa, and you guys could look this up and get the names, but I can tell it to you too. The mucosa, so here's the lumen, here's inside, okay, the digestive tract. This is, for example, what's pointing at is the epithelium. This next is the lamina propria, okay? So that's like that attachment, okay? And then here's the muscularis mucosa, because that's going to be a muscle layer, right? For the inner tunic, okay? Now, from the mucosa going out, we have the submucosa. Remember, we talked about areolar connective tissue, and you're going to be able to see that there are blood vessels, there are nerves, there are lymphatic vessels, there are some little bit of these glands found within, so the little globulate glands. Found in the submucosa, the submucosa, for example, we talked about the areolar connective tissue. I hope you could, this is not, let me just say, this is not a colored image, unfortunately, but you may want to color it in if it helps you. Just think of blood vessels, lymphatic vessels, nerves here, but within that, you have these intrinsic nerve plexuses. One of them is the myenteric, and you can look at it in your book, but I've got it listed on the handout below too somewhere, but myenteric plexus, what it does is it plays a role in releasing and contracting the muscle, okay, for that peristalsis to happen. And then we have a submucosal nerve plexus that's found there, okay, in the submucosa. So to provide, here you go, some nerves to the submucosa, that areolar connective tissue. Now, once you come down here, the next layer, because we've gone from the mucosa to the submucosa, now we're in the muscularis externa, meaning the external muscle layer. You have two layers. You have a circular, these are the circular muscles, and these are the longitudinal muscles here. Why would you have longitudinal muscles and circular muscles? What are they doing? What did we talk about that's happening to push food along the tube and break it up? Why are the circular muscles there? What are they doing?
Is it segmentation?
Yeah, they're forming segmentation. That's what's happening. That's what's squeezing the tube back and forth as the chyme goes through. It's breaking it up into smaller pieces, okay? Now, what about the longitudinal muscles? What action is it performing? So what other action?
The peristalsis?
Yeah, peristalsis, exactly. So peristalsis is forming the wave-like action, so longitudinal muscles are going to play a role in that. Okay, so that is controlled by the myenteric nerves, okay? Now, it's going to cause the contraction and relaxation to have these muscles contract and relax back and forth for segmentation and peristalsis. Okay, now the most superficial layer is the serosa. We have the, of course, it's going to be an epithelium, and then there's going to be a connective tissue underneath. So that's the most outer layer here. Here's epithelium, and then underneath it is connective tissue. Okay. So let's go back through these. Can't get this big enough, and I'm sorry. So you've got the first or deepest layer is the mucosa we talked about. The next one, the next deepest up, going out, heading to the superficial layer, we have the submucosa. Then we have the muscularis externa, and then we have the serosa on the outside. What would the serosa be called if it was, for example, your esophagus and it was above the abdominopelvic cavity? Like if you're above the abdominopelvic cavity, what would serosa be called? Do you remember the term?
Adventitia?
Yeah, the adventitia, exactly. Okay. All right, so I'm going to keep going. Now, we've talked about the main digestive organs are going to be the mouth, this, for example, the esophagus, and then you go down to the stomach, and then the stomach forms into the small intestines, and then the large intestines, and then the anus, for example. So all these main structures you're traveling through are going to be the primary structures of the digestive tract, okay? But then we have accessory structures that go in addition to help this breakdown of food, right? An accessory to the main structures, all right? So these will make sense if I mention it that way. So the accessory structures are, the first one would be teeth. So it's going to chew. Upper and lower molars are going to lock back and forth and chew. And then, of course, the tongue is going to be one of them. So mechanically break down food. You've got incisors. Incisors are going to be the front two teeth, those little chiseled teeth. They're cutting, biting, and nipping. And then the canines are the ones, you guys know your canines, the fang-like teeth that tear and rip apart, okay? For example, meats, hard, thicker, food-like substances. And then the premolars or the bicuspids or the molars are the crowns that are able to grind and crush, okay? So you're going to break down food that way. Then the tongue is going to provide gripping, constantly repositioning for mastication, for the chewing to happen. And then saliva is going to help form the bolus before it becomes chyme broken down further. So amylase is going to be produced in the mouth. You're going to have some chemical breakdown. The tongue is going to provide the mechanical pushing and helping the teeth to be able to chew or form mastication. And then you're going to initially swallow. From right now, you've got a voluntary action going on, okay? And then it goes down. Finally, it goes through the stomach, and then it gets put into the first portion of the small intestines, into the duodenum. Now, you have your liver produces something called bile, and bile gets stored in the gallbladder, okay? So the stored bile is going to be basically sitting there and then waiting inside the gallbladder, and then it will get released when you have food enter the small intestines. It gets released via the bile duct or the cystic duct into the bile duct, and then gets pushed into the duodenum, the very beginning of the small intestines, once it comes out of the stomach. Bile, which we're going to talk about next week, it is a emulsifier. It breaks down food substances. So all of this chyme gets broken down into smaller pieces. So it's kind of like a detergent. If you take it and you mix it up, and then you're going to break down the pieces to get smaller. Okay. The goal is to increase absorption area. Okay. That's what it's trying to do. Or surface area for absorption, if you want to think of it that way, is really what's happening. So liver makes bile, but bile doesn't enter the small intestines until the gallbladder contracts. So you have to get a signal to the gallbladder, and the gallbladder will contract once it knows food has gotten into the small intestines and it's ready to produce and push out bile. Okay. So the gallbladder is an accessory organ to the main tube or the GI tract. Now, salivary glands, there are 3 that you need to know. The parotid is the one that if you taste something sour and you're like, and it kind of tinges. Hopefully everybody has done that. It's not just me, but that's the parotid, okay, that sits in the back, okay? Then there's the submandibular under the mandible, and then sublingual under the tongue. So I do have a little picture of those we'll look at in a second. So cleanses mouth, moistens and dissolves the food and breaks it down and aids in forming the bolus formation, okay? It does contain the salivary amylase to break down the starch, all right? Now, that's obviously, those are going to be all accessory. The next one, of course, we've already talked about this being accessory because the gallbladder's accessory, so the liver's got to be accessory. So digestive function and producing bile. No bile, you have very little fat digestion or absorption. So keep that in mind.
I have a quick question. The one when like you feel sick, like you feel like you're gonna vomit. What is that? Which gland is that? Not that like happens all the time, but what is that one? That is like an intense one.
So that you feel sick with?
Well, it just feels like there is so much water in your mouth.
Oh, with the mouth. I know what you're talking about. Yes, that's the parotid. That's the one you're talking about. Yeah.
Okay.
That's the one that you can stimulate because it's easy to get things like if you have something sour or something like that, you're like, you have a lot of water that like you're going to kind of vomit with it. I know exactly what you're talking about now. Yeah, that's the parotid gland. Yeah.
Thank you.
So, or we call it the salivary gland. It salivates. Does that make sense? Okay. So
yeah, totally.
That's definitely, and you can feel it exactly where it's coming from because it kind of hits that nerve and it goes back and you're like, ugh. And then you over salivate and you're like, gross, I feel like I want to vomit. Yeah, I know.
Right.
Exactly. Yeah, that's the one I was trying to describe. All right, the liver, of course, we just talked about that, sorry. Pancreas is the next accessory gland. It functions to produce many digestive enzymes. So keep in mind, the pancreas is going to also push out its duct, and it's going to meet with the bile duct to have, and we're going to look at this next week, but they're going to meet together and they're going to push out not just bile, but digestive enzymes via the pancreas. Remember we talked about the pancreas has endocrine function and it has exocrine function. Remember we talked about that? The endocrine function is going to be the insulin and glucagon, right? The exocrine function, because it's excreting out a tube, is going to be the enzymes, the digestive enzymes. So trypsinogen, for example, turns into trypsin. We're going to help to break down some proteins further. The carboxypeptidase helps also with proteins or breaks down the peptide bonds, and the carboxypeptidase is what it's going to activate into to do that. The chymotrypsinogen forms into chymotrypsin. Okay, we're going to talk about all these next week. And then of course you have amylase, lipase, and nucleases that are going to break down. So the nucleotides, the fat, and then the amylase further. Okay. Okay, so peristalsis we've talked about. Here are the terms. We've already mentioned this, but it's the waves of contraction and relaxation of the muscles of the organ walls. Okay, I think this. I don't know why this grosses me out to mention it this way, but like roll a tube of toothpaste at the end. Gross. I don't know why. I always think that's gross. I guess because I think toothpaste is kind of gross. But anyways, segmentation. That's the non-adjacent segments of the intestines. We talked about the contraction, relaxation of those longitudinal muscles, or I said not longitudinal, circular muscles, backwards and forwards, okay? Peristalsis are the longitudinal smooth muscles that are found in the wall, and then the segmentation are going to be the circular muscles found in the wall, okay, that are going to contract back and forth and break up the food. And then deglutition is going to be the swallowing occurs, and that's going to be the types of swallowing that's going to happen. You're going to have the voluntary and then the involuntary portion. So we're going to talk about those in just a second. So you've got in the mouth, you have voluntary controlled, initiated by the tongue, and then you can kind of control the food before it gets broken into a bolus. And then you have the pharyngeal esophageal portion where the involuntary portion kicks in. So that's when it starts into peristalsis, and then further down into the small intestines, we'll have that segmentation happen, okay? So from the esophagus, go into the stomach, the peristalsis is going to start. So we're going to talk about that. I know, I feel like I could keep going on this handout forever and ever, right? So number one of the deglutination, the swallowing, that's the term for that. So now you know it on the handout. So what happens first is we ingest food and we have the esophageal sphincter is contracted. During the buccal phase, the tongue presses against the hard palate, forces the food or the bolus into, why is this overlapping? Into the oropharynx where the involuntary portion is going to start via the circular muscles. I don't know why this did this. This is really weird, but that's okay. It's just overlapping. I may have to resend this or attach it separately. I apologize. 2 is the uvula, that little thing that's hanging down the back of your throat. That's it. The uvula and the larynx are going to rise to prevent food from entering the respiratory passages, okay? The tongue's going to block off of the mouth. The upper esophageal sphincter is going to relax, allowing food to enter the esophagus. All right, 3, once the bolus is coming down the esophagus, the constrictor muscles of the pharynx are going to contract, forcing the food to the esophagus inferiorly, and then, of course, it makes sense, upper pharyngeal sphincter. So these little sphincters, these little, where it's going to close off, is going to keep pushing it down. Okay, hold on, I'll move over here. This is where it's overlapping on the page. It's really annoying. And then, of course, that's where the involuntary phase is going to happen. You have the bolus that's now coming down. Something I want to show you, though, you have a little sphincter here. This is going to be, and I know it's listed here as the gastroesophageal sphincter. Sometimes we call this the esophageal sphincter or the cardiac sphincter. We'll talk about those. I've got some images to talk about them again. So the gastroesophageal, esophageal, or cardiac sphincter, okay? Food will enter the stomach, and then eventually, once it's further broken down, it will turn into and push through another sphincter down here called the pyloric sphincter. All right. But as food is coming from a bolus formation, food will move through the esophagus and eventually via peristalsis go into the stomach, right? That's what we're just going through the handout. And then the gastroesophageal sphincter opens and food enters the stomach. But there is a gastroesophageal sphincter, or we should call it esophageal sphincter or cardiac sphincter, and then there's the pyloric sphincter down here. Like I said, I will mention those again because I'm about to show you some images I want you guys to be able to see. So bear with me, I have to take you off the share screen and put you back on in just a second. All right, hold on. Let's see. That's it. Okay, can you guys see an image of the digestive system?
Yes.
Okay, so here's the mouth. Here's what I'm representing, the salivary glands. There's the parotid gland we were talking about that makes it kind of tinge and water your mouth, right? Under here, you've got the submandibular gland, sublingual gland, which there's better images than that. You'll be able to see it via Anatomy Physiology Revealed. Here's the esophagus, so primary organ, accessory organs, the salivary glands. Here's the esophagus, which is the primary organ, into the stomach, primary organ, continuing all the way down the tube are primary organs. The liver is accessory, the pancreas is accessory, gallbladder is accessory, okay? Of course, teeth, tongue, or accessory. So food's going to come in, break it down, turns into a bolus. Bolus is going to travel down. Once it gets to the stomach, it's going to enter the esophageal or gastroesophageal or cardiac sphincter. Then it's going to turn into chyme. It's officially chyme at this point. Then chyme is going to go through the pyloric sphincter into the duodenum. Here's the duodenum so you can see it. Hold on, let me move down this image. There's the duodenum. The duodenum is going to have a duct where a duct is going to be combined via the pancreas, where its duct is going to push into the duodenum, and the gallbladder is going to have a duct. It's going to push in and push enzymes right here into the duodenum. The chyme is going to be broken down even further. It's going to come down because it's in the duodenum, eventually turn into the jejunum, and then eventually on down to the ileum. The ileum, here it's going to enter into another, or push through another sphincter called the ileocecal or ileocecum cecal sphincter. So the ileocecum, right, where they connect, and then the cecum is right here, the start of the colon. So here's the cecum, here's the appendix. The appendix is going to be kind of like a backup of good bacteria in case you get sick. Hence why it gets inflamed and infected sometimes. And then here's the start of the colon. We have a ascending, we have the transverse, and then the descending colon turns into the sigmoid, creates an S. And then the rectum is meaning straight, the rectum, and then the anus at the end. And then just keep in mind, through the small intestines, you're going to majorly have absorption happen. So the enzymes have broken down the chyme further. So absorption is going to happen. And then via the colon, you're going to have food matter. So food matter absorbs small intestines. Colon's going to be water matter, electrolytes, and vitamins in large intestines. Okay. Not to confuse you guys. Let me go down, see what other images I put on here. Oh, okay, here's the mouth we were talking about, just so you can see the teeth. Here are the incisors here. Canines, here's one of the canines, and then here are the premolars, and then here are the molars, okay? And then I think one of the other things I was going to show you needed to know, trying to think, there was something else on here. I don't think so. Okay. I put it on here. I was trying to think of something else you needed to know. Here's an example. We talked about the layers. Here's the lumen. Here's the mucosa. Next layer is going to be submucosa. It just says muscle layer. But muscularis externa is what we're talking about. And then the serosa. Okay. Just so you could have a general image to be able to see. Next is another image. So here's the liver in relation, so you can see the gallbladder, you can see the stomach, and just kind of where things sit. So small intestines, here's the colon, the transverse colon going across. So you can see where they're situated. I don't know, I was just trying to find good images so you guys could see. Okay, this is what I wanted to show you for the stomach. So we talked about the esophagus. Here comes the food, the bolus coming down. Here's this is why this is called also the cardiac sphincters, because this portion is called the cardia. Okay, this is the fundus where it pushes up. So that's the fundus. This is the body, the main portion of the stomach. Okay, and then down here is the pyloric antrum, I should say, or pyloric canal or region, another term. And the pyloric sphincter is right here, and this creates the start of the duodenum and the small intestines. Now, another thing I want to point out. There are, to increase surface area, you've got these things called rugae. So they're going to be these little like mounds of tissue. So the stomach is going to, it's kind of like the bladder. We talked about the bladder. The tissue, when it's smaller, or it's empty, I should say, I said smaller, when it's empty, it kind of pushes in together and creates these folds, right? Just like that transitional epithelium that's found in the bladder. But in the stomach, we call it rugae, because when the stomach is small, these little folds are appearing. But when the stomach gets stretched out, the folds disappear. But it isn't to increase surface area. Okay, so keep that in mind. So those are the rugae, the little folds. Remember, we talked about the omentum. We talked about it's basically these weird little folds, and I would love for you guys to pull up another image, not just what I'm showing you, even though I had a hard time pulling it up. This is what I wanted you guys to see. When you do the dissection of the pig, I want you to be able to see that the omentum lays over, here's the, for example, the greater omentum is going to lay over the small intestines. This is showing you the small intestines, for example, kind of a cross section of it, but it's going to lay over. It's kind of like a yellow, it kind of looks nasty. I hate to say it that way, but it has a lot of immune function in it, and it's going to lay over the small intestines and then drop down close to the large intestines, okay? There's a lesser omentum that's from the liver, and it's going to go down and attach, okay, itself to the stomach, and then from the stomach, the greater omentum is going to lay over the small intestines, okay? All right. Just wanted you to be able to see where it lays. That's why I posted that photo. Here is for the liver. You've got to know, you'll see this on Anatomy Physiology Revealed, the different, you know, here's the right, here's the left, for example, lobes. And then you'll be able to see here's the gallbladder underneath. And then you've got something called this is called the cystic duct. And then the hepatic duct meet together to form the common bile duct. Just for you to be able to see that. We'll talk about that next week further. I think that might be, no, it's not it. And here's the pancreas. So just so you can see where the pancreas sits, it's kind of like a little fish. It's kind of funny when you look at it during dissection, it looks like a little flap, like a little fish. It's going to sit right here, kind of the duodenum wraps around it. So just keep in mind, this would be like the stomach is right here. Here's going to be that sphincter, the pyloric sphincter, and then food's going to pass, or that chyme is going to pass down into the duodenum. Here it is. And then here's the major papilla where it gets pushed out, okay, the enzymes, digestive enzymes, to further break down that chyme as it passes through to the rest of the small intestines. So we're going to focus on this next week. The bile that's secreted, I'm going to go back to some good images with this. This is just so you can see the general structures of the liver and the pancreas and where they sit and what happens with the bile, where it gets secreted out in the duodenum, and also the digestive enzymes from the pancreas. Okay, I think that's my last image. Nope, it's not. Look at that. So, and then this is just a picture of the colon. So the ileocecal valve is found here. Here's where the ileum is going to attach to the small intestines. Here's the cecum. Here's ascending colon, transverse, descending, sigmoid, rectum, and then the anus. Okay. But something I want you to be able to see, and you've got the same, or not the same image, you've got an image like this on the front page of the instructions for this lab on eLearn. Look at those, because some of the things are, you know, shows you to be able to identify certain structures. Like, for example, this little cluster is called a hostra. Each one of these is a hostra. The Taenia coli, oh, this is labeled here too. That's the muscle that attaches and kind of pulls it together to form the hostra, because it's really tight and pulls it. And then you've got on the sides the hepatic fixture, where it holds to the back or posterior retroperitoneal of the wall, okay, that back portion wall, right, of your peritoneum. All right, so now that is the last of the pictures that I wanted to go over. However, I wanted to go back. I'll have to unshare and then reshare my screen. So let me go back over here, and then let me hit share again. Okay. All right. Can you guys see the last page of the handout?
Yes.
Okay, good. So let's go back to the instructions. So we have done the objectives. We're going to go back to some of this stuff next week, but I want you guys to go through Anatomy Physiology Revealed, point out all the images. We talked about them. In fact, I can post the images on the handout. I can post those too if you guys would like them. Of course, I'm going to go through your quizzes from the urinalysis and give people credit for question 2. So that's still something I need to do. And then please go through all of this. And then the last thing, of course, that we wanted to talk about is the dissection. I think I've really kind of already focused on this enough, but at the same time, I want to just point back to this, okay? So the dissection, make sure you go through each one of the things. Also, of course, watch the video, but each one of these gives you specific things to do. Of course, this is personal stuff right here to clean off your area and do all that. But follow instructions, prepare your labeling pens, small piece of paper, okay? Label the pens 1 through 6. Follow the instructions of the photo. Take a clear photo. You can use more than one pen in one picture as long as it's clear. Put your name and date, which image set, right? Then image set 1, these are the pens, okay? Okay, and then here's the next one, image set 2. Make sure, like I said, name the image set. Here's different pens for that image set. Image set 3, the different pens. So you've got to be able to label these out and make sure you give me the image set, not just the pens with the numbers, okay? Remember, the name and the date on each image needs to appear in each one of those images, right? So here we go through all the sets. Now, if you upload, please remember, like I said, it has to be in a certain format. We've labeled it here. Hold on, where's the format listed? Okay, here it is. The JPEG here, all these formats, it has to be in those formats in the Dropbox. You guys should be familiar with all this at this point. Should not be hard. And not to forget, you have a post-lab digestive quiz. I think that one's due on the 12th. I have to pull it back up.
Do you mind scrolling back up to the top to find exactly where this is? This is where I always have trouble. I have to look for it for like.
This is the Lab 8 instructions, digestive anatomy.
Thank you so much. Okay, perfect.
So if you go back to chapter 25,
Mm-hmm.
I didn't mean to do that. Sorry. I hate this too because I have to get out, go back.
I just feel like I look for it like 3 different times.
Look for it forever. That's what I do, the same thing. So here I am. Okay. So this is Lab 8 instructions, digestive anatomy, and then I have my lab handout comes next.
Right.
Then next week we'll go over the physiology portion, the enzymes. Okay. Then you'll have a buttload of virtual labs due, and then the dates on here.
And what exactly is a buttload?
A buttload. Let me show you a buttload. That's a buttload. Here you go. All those. So those are a buttload. And let me see. This one's okay. This one's the one that's due a little sooner. So make sure you don't miss this.
Mm-hmm.
Post-lab digestive quiz is due November 8th. The virtual labs, your buttload of labs, those are due November 15th. You see them? So I'm just saying a buttload. It's more than normal, okay? It's more than what you're used to. These are going to be.
It is funny. Last unit did not have this many, and I went ahead and did all of them.
Mm-hmm. Yeah, it didn't have this many, and the reason that I was trying to explain to you guys, because if we were physically in lab, next week, we would have you guys doing all of these tests on the different enzymes and bile and all of that. So, for example, next week, don't do these yet, but next week I would focus on doing these for your lab time. But the test for sugar, test for protein, next one starch. So there's starch. And then that's all. Thank God that's all of them. You don't have a bile one. We'll just discuss bile next week. I figured you would, but you don't, which is probably a good thing. Oh, here it is. No, bile. That's bile, emulsification of fat. Okay, so then you've got that one. So that's why I say it's kind of a buttload for next week. It's less us discussing, and it's more you doing the virtual labs, unfortunately. I'm sorry, I apologize, but that's what it is. But we'll talk about it before you do it and what kind of things you'll be looking for, if that makes sense. So this is next week, the Lab 8 instructions, digestive anatomy. It's this week, but please keep in mind you have the post-lab digestive quiz November 8th. So that's related towards tonight. Okay. Are there any questions of what is expected of you? Anybody? Okay, give me like one of those emoji thumbs up if you feel comfortable with what's expected of you. Or you'll contact me later and ask me if you feel uncomfortable right now. Give me, okay, cool, great. All right, so if you're not sure what's expected of you, please email me or text message me and I'll put you in the right direction, okay? All right, cool. So I'm going to sign off and say good night, good luck, and reach out to me if you have questions, concerns, or need help, okay? All right.
Awesome. Thank you.
You're welcome. Bye.